In this video, we're going to talk about osteoarthritis. This is an overview and introduction. We will mainly focus on osteoarthritis of the knee joint because it is a very common condition. Now, before going into osteoarthritis, we should revise the synovial joint and its anatomy because one, the knee joint is a synovial joint, and two, osteoarthritis occurs commonly in synovial joints. So, the bones that form the joints are surrounded by periosteum. Remember, the periosteum is a very painful and sensitive structure because it contains pain receptors. The ends of the bones are surrounded by shiny substance called articular cartilage. This cartilage helps in absorbing shock and also allows for gliding between the bones. Surrounding the synovial joint is the synovial membrane. The synovial membrane produces what's known as synovial fluid. Now, surrounding the synovial membrane, you have the fibrous capsule, which together with the synovial membrane forms what is known as the articular capsule. The synovial joint is also further stabilized by ligaments. And there are many ligaments depending on which synovial joint you're talking about. Let's look at another diagram now, drawing out the same structures. The blood vessels supplying the articular capsule help bring in immune cells and also help bringing in nutrition, but it also is necessary for draining waste. This area is also innervated by nerves, nerve fibers. We talked about a type of cartilage called articular cartilage that surrounds the ends of the bone. Well, in a knee joint, there is another cartilage, a fibrocartilaginous cartilage called meniscus or menisci for plural. Menisci are like wedge discs stuck between two bones, and it really helps with the joint stability and helps also in absorbing shock at the joint. A good example is the knee meniscus, which when you run absorbs the shock on impact. When you are young and healthy, you are mobile and your joints are stable and strong. In osteoarthritis, you have degeneration of the joint. More specifically, degeneration of the articular cartilage. You have articular cartilage breakdown, damage, and degeneration. This is in the presence of joint space narrowing. We would call this mild osteoarthritis, which is very common when we age. However, there are many risk factors which predispose and increase the risk of early osteoarthritis. These include age, being female, well, this is specifically for the hip joint, obesity, which increases stress on the knee joints, previous joint injuries such as sports injury, and also having a lower leg deformity or malalignment such as bow legs or knock knees. This essentially means having a valgus or valgus feature at the knee joint. There are also some rheumatic diseases and genetics that are risk factors for developing osteoarthritis. Once mild osteoarthritis occurs, progression is inevitable and can be slow or it can be fast. Severe osteoarthritis eventually occurs. Here, you can have bone on bone, joint space narrowing, loss of articular cartilage, and formation of bone spurs called osteophytes. One way osteoarthritis is categorized is into primary osteoarthritis or secondary osteoarthritis. Primary osteoarthritis is idiopathic, where there is no preceding injury, and osteoarthritis is basically a result of old age and degeneration. Secondary osteoarthritis is different. It is usually due to something else. Examples include congenital abnormality, trauma, and inflammatory arthropathies. Clinical presentation of osteoarthritis. So the signs and symptoms include pain, which is exacerbated with exercise and relieved with rest. Weather has also been shown to influence the pain. There is also stiffness, of the joint. In severe osteoarthritis, pain can even occur at rest and at night. In severe osteoarthritis, you can also have malalignment of the knee joint. You can have genu valgus or genu valgus. And this will depend on where the osteoarthritis is located at the joint, if it's medial or lateral. On clinical examination, there can be muscle wasting. The patient may be overweight. In osteoarthritis, there is often tenderness on joint palpation, plus minus osteophytes. There can be presence of joint effusion during acute exacerbations. Crepitations is common, and there's also reduced joint movement because of stiffness. Differential diagnosis for osteoarthritis can mainly be crystals being within joint space. This is known collectively as calcium pyrophosphate crystal deposition disease. It can also be gout, for example. Another differential diagnosis is septic arthritis, where bacteria invades the joint space, essentially, and this is a medical emergency. Rheumatoid arthritis is another differential diagnosis, especially in the elderly. This is characterized by immune cells and complexes attacking the joint tissue and the joint space. Let us now talk about the pathophysiology and how these signs and symptoms arise and the clinical features. Here again, I am drawing the synovial joint of the knee specifically. Here are the two bones, for example. And this is the progression. As you can see with the bones, there are some abnormalities, bone changes in osteoarthritis as it progresses. In blue, covering the bone surfaces, are articular cartilage, which is hyaline cartilage, which, as you can also see, is slowly degrading as osteoarthritis progresses. The synovial joint is not a synovial joint without the synovial membrane here. And the synovial membrane is made out of cells called synoviocytes. These guys produce synovial fluid. Within the bone, you have many cells, including osteocytes, which then can become osteoblasts. Osteoblasts are the bone building cells. There's also another important bone cell, which I have not drawn here, called osteoclasts, which break down bone. Anyway, there is blood supply to the synovium. Within the synovium, you can find tissue macrophages. Now, the actual pathogenesis of osteoarthritis differs, and there's no exact one start-off point. But we know what cells are found within the joint tissue, and this is just an overall example of what happens. So the tissue macrophages can become stimulated because of a variety of reasons. For example, it can be stimulated from trauma, from joint abnormalities or malalignment, degeneration of tissues, and basically the risk factors of osteoarthritis. So this will activate these immune cells, and which will cause the release of many chemicals and inflammatory cytokines. So for example, the macrophages will release cytokines TNF-alpha, interleukin-1b, and interleukin-6, VEGF, and stimulate E-selectin. VEGF essentially will cause new blood vessels to form. It's an important factor in angiogenesis. E-selectin essentially is where the cells around the vasculature will express receptors, E-selectin, so that other immune cells can be recruited to the area. And so VEGF and E-selectin, together with the cytokines, will promote inflammatory cell recruitment and the inflammatory process itself. You get recruitment of immune cells, such as T cells, specifically T helper cells, and this will further produce cytokines in response to trauma and other factors. Neutrophils is another immune cell which gets recruited and is mainly important in acute inflammatory response, so it's not that common in osteoarthritis. T cells, macrophages, and all the cytokines produced in the area stimulate the synoviocytes to produce proteases. The neutrophils already in the fluid also produce proteases. Proteases are enzymes which break down proteins, and these guys are very destructive. Thus, they can damage surrounding tissues, mainly the cartilage. The cytokines also stimulate osteocytes, which in turn activate osteoblasts to build new bone to compensate. This is a sort of repair mechanism. When there is damage and inflammation, the osteoblasts will work and will aim to repair the bone that is getting damaged, thus causing what is known as subchondral sclerosis, which is whitening below the cartilage. In the long term, the depositing of new bones causes osteophytes, which are these bone spurs basically, and these are abnormal. It is important to take into account that with age there is thinning of the cartilage, and this is caused by decrease in hydration to the cartilage. Age also leads to brittle bones and chondral calcinosis. All these factors increase the risk and progression of cartilage destruction. It's also important to note that all the risk factors we talked about earlier increases the risks of cartilage degradation and destruction. So previous trauma, joint malalignment, etc. So how does pain occur in osteoarthritis? Well, in summary, remember that there are many cytokines produced in osteoarthritis. Some of these cytokines are pain signaling molecules, such as some types of prostaglandins and also bradykinin, or BK. These guys stimulate nearby sensory neural fibers. The sensory neuron will go to the level of a spinal cord and synapse with a second order neuron there, which then will bring the information up to the brain, where essentially the sensation of pain or pain perception is captured. If you're interested to see how pain is processed and works, I have a video on pain as well. It is also very important to understand that people have different pain tolerance and sensitivity. The longer a person feels pain, the more chronic it becomes, and this means there is an increase in pain sensitivity. But so interesting, some people with severe osteoarthritis feel minimal pain, and that's just because of variation. They still have a limp and problems with mobility, but pain is not really an issue for some people. Finally, it is important to introduce joint aspiration, also known as arthrocentesis, which is a type of investigation that looks at what is inside the synovial fluid. It is an investigation performed with any patient presenting with monoarthritis, one inflamed joint. This is important because doctors want to differentiate between other causes of monoarthritis, such as ruling out septic arthritis or gout. Anyways, synovial fluid aspiration involves drainage of the fluid from the joint space, then analyzing the fluid with microscopy, staining, or with microscopy, culture, and sensitivity. In general basic osteoarthritis, joint aspiration can reveal leukocytes, a neutrophil count that range up to 2,000 microliters. In septic arthritis, this number is way higher, 50,000 plus. Finally, let's look at an overall management and algorithm for osteoarthritis. So it's important to take a history to find out any trauma or associated fever. Next, it is important to examine the joint. And if it's a knee joint, perform a full knee examination. An investigation that is very important initially is an X-ray of the joint. For osteoarthritis, there's a good acronym to look at the changes seen in osteoarthritis. This is LOSS. L is for loss of joint space. O is for the presence of osteophytes or bone spurs. S is for subchondral sclerosis, or the other S for subchondral cysts. Another investigation that can be performed is to help exclude differential diagnosis and look at the severity of osteoarthritis. And this includes looking at ESR, rheumatoid factor, and anti-CCP. Joint aspiration can also be performed, and we talked about it earlier. An MRI is very good for looking at soft tissue involvement. But remember, X-ray is better initially. After diagnosing osteoarthritis, you can have non-pharmacological management or pharmacological management. Non-pharmacological management include losing weight, educating the patient about osteoarthritis, physiotherapy, using a walking stick, using a knee brace, appropriate footwear, and acupuncture has also been shown to benefit some people. There's also heat and cold therapy. Pharmacological management include, first line is using paracetamol, and then topical non-steroidal anti-inflammatories or capsaicin. This can then be moved on to oral non-steroidal anti-inflammatory drugs. But prescribing of oral NSAIDs means that you also have to prescribe proton pump inhibitors to prevent any gastric problems. Other pharmacological stuff include glucocorticoid injections, which are usually used for exacerbations of osteoarthritis. There's also viscosupplementation, such as Synvisc. Opioids are used sometimes, and this is in severe cases and for those who cannot undergo surgery. Other forms of supplements include glutamine and chondroitin, which has differing results. And finally, turmeric and fish oil is also shown to be beneficial. Finally, obviously, there is knee surgery, which can involve a total knee replacement. And this is the last line and is shown to improve knee joint pain and mobility. Thank you for watching. I hope you enjoyed this video.